providers will shape where the premiums go. Then you'll have the medical loss ratio issue, et cetera, et cetera. Can't say that it doesn't say premiums will be no higher than X. It will be a process to arrive at a level that is sustainable. There will be premium subsidies for people below family of four making $88,000, and those will be available for the public plan or a private insurance product in the exchange.
Can I ask a follow-up, because that was my question? I'm wondering, since it's a public plan, are premiums going to be set on the basis of the large group rate that you would have, like say, for the employees in the state of Delaware? Or since individuals will be buying it, will it be set at a typical individual rate that you would have to pay for private insurance?
It would be more like the rate of a public employer, a state employee system. And here's why. You would have a public plan where the federal government is negotiating with providers for reimbursement rates for what they're going to pay the doctors in the hospitals. They will have to bring in enough premiums to pay claims, but they won't need to pay a CEO salary and they won't have to pay profits. So the advantage to the public plan and why it's been a very thorny issue is the ability to operate without a profit margin. And so the rates will not look like what is in the unregulated non-group or private individual market, and those are, for most people, quite high. It will look more like what the state employee plan looks like, or better. And I actually think, let me just say that the private insurance plans who will be offering products within the exchange, and there's 3 products they have to offer, and they're very standardized, and there's a lot of transparency, so you'll know exactly what you're buying, which something in and of itself. If you've ever tried to decipher an insurance plan, I do it for a living and I still don't know what I've got. So you'll have 3 products in the exchange that a private insurer must offer. You will get subsidies if you're lower income, below $88,000 for a family of 4. And there will be a lot of regulation that will lower those premium prices from what we see in the current individual market, where again, a large portion of premiums isn't going to pay for health care services. It right now goes to pay for profits and CEO salaries and advertising and all sorts of things. So the private insurance products in the exchange are going to look radically different from what we know of in the private insurance market today. And the public plan option gives people another choice, and they'll compete, and we'll see how that goes. That's the scheme. There's a lot of hybrids of the public plan option, and I am open to those, and I think a lot of folks are open to talking about those if they mean that we are not having a profit-driven system, but we're having a public plan that has, in the co-op model, doesn't involve, again, high CEO salaries. Do you guys know what a health insurance industry CEO makes? Do you have any sense of this?
Hundreds of thousands of dollars.
Millions. Not as much as pharmaceutical industry CEOs, I will say that. They come in higher. But we're talking $40 million a year. So there's a lot of room to bring down to find some savings here.
Compared with pharma?
Pharma's higher. Pharma can be much higher. Oh boy, let's see, there's a report on our website that looks at pharma CEO salaries. We did it back during the Part D debate. You're getting into hundreds of millions of dollars a year with stock options and compensation. So, it's not hard for them to drop, a couple $100 million on an ad campaign. They just have to hold their noses for a year and take it out of their own salaries. I mean, I'm being a little facetious here, but it is a pretty amazing centerpiece of power in our country. So I don't know.
I'm being signaled that I can only do one more. So I've heard nothing about reducing costs from tests run predominantly because they are largely covered by insurance and because they keep the doctor from a potential malpractice charge. Why can't we cap malpractice awards? What can be done to reduce the proliferation of testing?
Well, first First of all, one of the areas of controversy in the bill for holding together the political support of more conservative Democrats, I'm not talking Republicans here, folks, I'm talking conservative Democrats who may be familiar with this concept here in Delaware. And I think medical malpractice is one of those places where we could derail healthcare reform. So the game right now is to find moderate ways to approach medical malpractice with some review panel type approaches where you're screening for what kinds of lawsuits are brought and eliminating some frivolous ones. But frankly, there is not, you will not find a compromise that moves towards significant limitations on awards, I think, in healthcare reform. There is also the concept of comparative effectiveness research, which is what the opposers of healthcare reform often will point to when they say that healthcare reform will ration care. And what it really does is make care a little bit more rational. So it will, and you've all heard the president do the red pill, blue pill thing, and you've heard but it will really say, let's not decide what can be reimbursed by insurers, but let's make sure that doctors and consumers have good information about what treatments work and what doesn't, include, and be able to make decisions about whether they really need this course of treatment rather than this. There is no authority to determine what will be reimbursed by insurance companies, because I think there is a legitimate fear out there that might go too far. So that's in there. The other thing is there's a bunch of reforms that aren't being talked about at all in the Medicare program, which drive the rest of the healthcare system, that really just deal with things like coordinating care among providers and hospitals, care coordination, and making sure that the doctors actually work together better. And I actually haven't seen the right go after this. They haven't figured out a way to bash it, because it's such a common sense idea that we're going to have reimbursement policies that look at the full course of treatment and all the providers who come into play to get a person out of a hospital and keep them out of a hospital. There's also provisions about people who end up going back into the hospital who clearly should not have. And this is clear, like, you took the wrong leg off kind of stuff. It does happen. You left the sponge in. Clearly an area where there's some medical malpractice issues, but also making sure that our system doesn't reward that kind of really blatant malpractice by physicians through the Medicare program. Those are all things I think are very positive. They are not going to take away the benefits that seniors and people with disabilities can access, but they're going to bring some rationality to our healthcare system that may help with some of the medical malpractice-driven premiums. And, I will say that Families USA is staying out of the medical malpractice debate. It is so loaded that it really could derail healthcare reform. Is that it?